Hello and welcome to the final video on adrenal gland pathology. Here I'm going to talk in more depth about functional adrenal disorders and review the general adaptation syndrome, that is the body's response to stress, very important for us to understand clinically. And then I'm just going to mention a few things about aldosterone secreting tumors and adrenal medulla disorders as well. So in the adrenal anatomy and physiology videos, I already went over this notion of HPA axis dysregulation in functional adrenal disorders. And the research around this goes back to the work of Hans Selye and his general adaptation syndrome, which is how organisms respond to stress. What he found, primarily looking at research on laboratory animals, is that there are three basic phases of the stress response. And what's important about this is that these are all modifiable with the different kinds of therapies we can use supportively. So the first phase of the stress response is the alarm phase. This is the initial phase, and this is characterized by overactivation of the sympathetic nervous system. There's a little bit of activation of the HPA axis, but it's mostly the sympathetic nervous system. And this can lead, though, over time to catecholamine depletion. So you get an initial excess with all the symptoms of elevated catecholamines, like increased heart rate and sweating and so forth, anxiety, and then more of a burnout. As you've depleted those stores of catecholamines, now they have to be resynthesized, and that can take a little while to do sometimes. The primary approach to this phase, especially the sympathetic excess phase, is to use nervine herbal therapy. So using level 1, but especially level 2 therapies, herbal therapy using nervines. There are different micronutrients that can support this as well. So giving the precursors to dopamine or epi like tyrosine, giving 5-HTP serotonin, different B vitamins, 5-HTP to increase serotonin synthesis, different B vitamins, especially the methylated folate and B12, zinc, magnesium, GABA, and L-theanine would all be potential nutrients here. GABA is a little controversial. I'll just say, GABA is an amino acid, and if you eat this, it is primarily metabolized. So the question is, how does it get to the brain? Well, what we're finding is something very interesting, and this is true for a lot of natural products, is that when you ingest GABA, this has been shown in animal studies, not in human studies yet. When you ingest GABA, it's metabolized, but in the process of metabolizing, the vagus nerve senses that in the gut, and then it triggers mechanisms to increase GABA secretion in the central nervous system. So it's not that you take GABA and it actually gets into the blood and goes across the blood-brain barrier into the brain. It's more that it triggers a reflex mechanism to cause your brain to start synthesizing and making its own GABA. So that's why we think GABA therapy might be helpful. So that would be for the alarm stage, using nervines and those supportive micronutrients. For the resistance phase, here we get usually overactivation of the HPA axis. There's going to be usually hypercortisolism, or at least during different times of day, an increased cortisol DHEA ratio. What happens over time, though, is the DHEA can start to decrease. So we get high cortisol, but the DHEA levels start to go down. And remember that DHEA is the main hormone which protects you from all that extra cortisol, and so we get less of a buffer there. This is really very similar to what we already talked about, is pseudo-Cushing syndrome. In fact, we can say they're really just variants of the same thing. So here we're going to have high cortisol, which is a catabolic hormone, and that's going to lead to the central weight gain, fluid retention, hypertension, dysglycemia, insulin resistance. In females, we'll see more estrogen, decreased progesterone, and possibly metabolic syndrome. Versus in the low, with the DHEA going down, we're getting less of the anabolic effects, so less muscle mass, more weight gain, less immune tolerance or immune function. And then in males, we'll see decreased testosterone and increased dihydrotestosterone, which has negative effects on the prostate, hair follicles causing balding, as well as acne, and we'll look at that in the male reproductive section. But also decreased growth hormone, decreased IGF-1, which might predispose one towards type 2 diabetes. So that is the consequences of having a chronically overactivated HPA axis, high cortisol, and eventually the DHEA starts to go down. Note that if your patient is on prednisone or actual cortisol, hydrocortisone therapy, that's always going to lower DHEA. And so those are just things that we can keep in mind to maybe think about the need to support DHEA while they're on those medications. The phytotherapy for this would be primarily using sedative adaptogens. So micronutrients also, like phosphatidylserine, manganese, and lithium, the small dose, very small doses of lithium, not the kind of doses we use in bipolar disorder. Sedative adaptogens, I already went over those, but that would be like the ashwagandha, bacopa, and holy basil. All right, so that's the overactivation. And then with time, Selye noticed that the animals began to experience adrenal exhaustion. We might call this the pseudo-Addison. So this is not true Addisons. The adrenals continue to secrete, but it's kind of that pseudo-Addisons. We see a disturbance of the circadian rhythm, and we see low cortisol with hypotension, more dehydration, maybe hyponatremia, hypoglycemia, and more pain and inflammation. And one hypothesis is that in these states, the liver actually starts to synthesize more LDL to try to compensate. That's just a theory. I don't know of any strong evidence to support that, but that's something you hear in some of the functional medicine circles. We get low DHEA as well, and that's going to result in loss of muscle mass and endurance. So here, both cortisol and DHEA become lowered. And the treatment for this would be stimulant adaptogens. I should just say Selye never talked about these herbal therapies and whatnot. This is something that came later, but this is something I put together in relationship to his general adaptation syndrome. That's, I think, important to note there. And then different micronutrients, vitamin C, B5, B6. These are important B vitamins for the adrenals, B5, B6, and then copper and iron. And then adrenal glandulars could potentially be useful, but here we want to be sure not to use hydrocortisone. Unfortunately, there are, I don't know if they're still out there, but I know years ago there used to be some products on the market labeled as glandulars that actually had hydrocortisone added. That's not good, because that could potentially risk suppressing the adrenals further, and that could even trigger an adrenal collapse over time. But you can also start getting Cushingoid symptoms from taking too much hydrocortisone. All right, so that would be the three kind of level 2 approaches we can use to address the 3 phases of the general adaptation syndrome. Very common in the clinic, and what I often am doing with patients, especially if there's any sort of stress-related disorder, I'm trying to find out which level of this are they on. What I've noticed is that patients don't have to necessarily progress from the alarm to resistance to exhaustion. They can go right to alarm to exhaustion. They might stay in resistance for many, many years, etc. Or some are just constantly in the alarm stage. So that's where we can start to use a little bit more of the art in the clinic of putting this together to understand how to support them. Here I've just enclosed some tables of some of the herbs. This would all be, again, level 2 therapies to address the functional adrenal disorders, and the classic nervines to address the alarm stage. So passiflora, motherwort, skullcap, valerian, lavender, melissa, chamomile, jujube, the albizia tree, the bark, the bugleweed, linden flower, etc. So in your herbal studies, you've probably come across many of these nervines. We think that most of them are working by decreasing sympathetic nervous system activity. We might call them indirect beta blockers. So they have sort of a medicinal profile similar to beta blockers, but they're not acting at beta receptors to block them. They're going to increase vasodilation, decrease blood pressure, decrease palpitations and anxiety, improve endothelial function, decrease inflammation, and they're antispasmodic. And we think they also increase melatonin secretion, and they increase GABA secretion. So all very helpful effects. And some of the primary constituents are flavonoids like chrysin, which is also an aromatase inhibitor, but also volatile oils like some of the sesquiterpenes, bisabolol, farnesene, chamagiline in the chamomile, etc. And then some, like the Passiflora, even have alkaloids in small levels, the Harmala alkaloids. And some herbs, like Passiflora, again, even have GABA, and then some even have small amounts of melatonin in them as well. Different nutrients that can support micronutrients, so that can support these herbs, would be zinc. Zinc acts as a glutamate antagonist in the brain, and we think it also can help upregulate GABA. Gold, there's no real biomedical research on this. This is more of a historic use. Gold has an affinity for what is in traditional medicines called the heart system. That includes the heart itself, but also all the sympathetic activity of the heart. So when you have palpitations, anxiety, gold was thought to be a regulator of that activity. So I sometimes use that in homeopathic or in what are called oligo-element dilutions. An oligo-element is basically a trace element that is in a 1x dilution. So that's 10 to the minus 1 dilution. So a very small dilution of gold nanoparticles, and you can get those as remedies. Again, I have not seen, the only place we use gold biomedically is actually in rheumatoid arthritis treatments, and even there, gold salts are very rarely used today. Arsenic, this is in the homeopathic range, not in the material range, and that is used as an anxiolytic, and then copper, also in small amounts, is used as an anxiolytic. So I just put those there to maybe think about. You can read about the indications a little bit more clearly in the homeopathic literature. I'll tell you a little bit about that. And then different nutrients like B vitamins, melatonin, L-theanine, and GABA, again, can all support the nervine activity. One final thing I'll say about nervines, if you look at a lot of them, they actually have purple violet flowers, which is kind of curious. And almost you can look at the flower color as sort of an indication of what the herb might do physiologically. We often think of purple violet as very sedating, very calming to the nervous system. So if you think of lavender, all these, they all have that similar kind of flower. This is more of a qualitative connection, not so much based on chemistry or anything like that. All right, so that's the first category of herbs, nervines, to address the alarm stage of the general adaptation syndrome. So the next grouping of herbs here, again, for a little bit more detail, would be what I'm calling the sedative adaptogens. Not really a great name because, again, adaptogens are not sedatives or stimulants, but I chose that name to sort of indicate that there are adaptogens that downregulate the HPA axis. And so herbs like withania, Chinese skullcap, bacopa, centella, polygonum, magnolia. Again, we should put holy basil on there as well. Gardenia, convolvulus, cava would all go in this range. I found that low-dose naltrexone probably also works in this range, and that's, again, naltrexone around 3 to 5 milligrams. In the homeopathic dosage ranges, belladonna, hyoscyamus, stramonium datura, all the Solanaceae, nightshade family plants, tend to help downregulate the HPA axis. And I'll say also in the homeopathic literature, there's another very important family that's used, and that's the buttercup family. And that includes pulsatilla, Staphylos agria, which is blue delphinium, aconite, all those different herbs in the buttercup family. And if we look at their chemistry, the alkaloids in those herbs, in very small amounts, are also down-regulating the HPA axis. So if you look at the homeopathic literature around those remedies, they often involve some degree of HPA axis overactivation. Manganese and lithium could potentially also down-regulate the HPA axis. And then phosphatidylserine has a fair amount of literature out there on it, and then L-theanine for decreasing the HPA axis. So in doing so, all of these are going to try to downregulate excess cortisol secretion, hopefully help to improve the ratio between cortisol and DHEA. So that's going to address all those different symptoms. One of the characteristic compounds found in adaptogens are the triterpenes. These compounds are very similar to the cholesterol backbone. And if you look at, for example, this is in ginseng, which is in the wrong category here. But if you look at a lot of these triterpenes, they have a sugar moiety, glucose, for example, attached. That is removed by salivary amylase and by pancreatic amylase. So we're left with the aglycone here, which is a triterpene. And notice this is very similar to the structure of your adrenal steroids. So the idea is that they're kind of an analogy ways. They're kind of helping support in the right ways the adrenal steroid production. One of the mechanisms we think these herbs are working are to essentially sensitize the hypothalamus, the glucocorticoid receptors there in the hypothalamus, to the levels of cortisol in the blood. So as cortisol goes up, that should turn down the HPA axis. But if you have chronic stress or inflammation or these other things we've talked about, those glucocorticoid receptors downregulate, and we actually get a misadjusted HPA axis. So one theory, and this has been pretty well established in the research literature about adaptogens, is that they are, in the case of these adaptogens, turning down, or they're actually upregulating glucocorticoid receptors so that we can turn down the HPA axis appropriately. So that is the sedative adaptogen. Other names you might hear: kidney relaxants, etc. in this category. All right, so that is to address the resistance phase of the general adaptation syndrome. Finally, to address the exhaustion phase with generally lower cortisol and DHEA and dysregulated HPA axis, we're going to think about using adaptogens to upregulate that, and I'm calling these the stimulant adaptogens. And that would include the Panax species like Panax ginseng, but also American ginseng, Eleutherococcus, Codenopsis, Pseudostellaria, Rhodiola, Astragalus, Schizandra, Avena, and licorice. Avena is questionable. It has different chemistry than these other herbs. It does not have the triterpenes. So we think this is more of a nervine, but sometimes put into the exhaustion phase, it's more of a nutritive nervine for those purposes. Again, gold, but also selenium, I have found to be very helpful here in small doses. Selenium, again, is a cofactor for glutathione and general antioxidant protection. It's also going to help improve your thyroid hormone activity. That was discussed in the thyroid section. And so this often goes along with these herbs in improving the HPA axis. Vitamin C and B5 are additional nutrients to help adrenal steroid synthesis. So we can think of these as regulating the cortisol DHEA rhythms, also having some effect on androgens like DHEA, but also testosterone, and then progesterone as well. So they generally would increase the HPA axis, increase general immune activity, and insulin sensitivity. I find these herbs help shift people away from a Th2 to a Th1 type of immune response to help them fight infections better, but also to decrease allergies and histamine. So that would be this category of herbs, the stimulant adaptogens. A lot of adaptogens on the market are all just put in the same bottle. So we see ashwagandha and ginseng and astragalus all mixed in the same bottle. I find it's very helpful to separate them into these two categories. Again, this category would address more the exhaustion phase on the general adaptation syndrome versus the more sedating adaptogens to address the resistance phase. So to identify those clinically and then give the appropriate treatment can be very important. All right, so that is an overview of the herbs and the treatments we might think about for the functional adrenal disorders. Just want to say a few words about a couple of other adrenal issues we haven't discussed yet. One is hyperaldosteronism. And aldosterone, again, is released in response to the angiotensin II levels in the blood. And what aldosterone is going to do is suppress renin production. It's going to cause sodium and water retention in the kidneys. Now, excess aldosterone from any source would generally result in high blood pressure, low serum potassium, high serum sodium, and increased urine pH. Excess aldosterone also causes increased hydrogen ion secretion, so that would over time lead to metabolic alkalosis as you excrete more acid essentially through the kidneys. And then we might see with severe hypokalemia, muscle weakness and cardiac arrhythmias. So that would be the kind of the clinical manifestations of high aldosterone states. And aldosterone can be raised either primarily, and that would be from an adrenal tumor, and that's what we call Conn syndrome, and that's high aldosterone, low renin, Or secondarily, we have high aldosterone, usually from high renin. And so the causes are going to be different here. So for Conn syndrome, we're going to have a benign adrenal cortical adenoma or potentially adrenal hyperplasia. The adenomas can be small and often missed, so sometimes the initial imaging might not show anything if you order that. But this should be considered. And so for patients presenting with hypertension, we actually always want to think about secondary causes of hypertension in addition to essential or primary hypertension. Remember that with hypertension, 95% are primary hypertension. We don't really know of secondary causes, although definitely metabolic syndrome, all that can be playing a role. For secondary hypertension, these are known causes of hypertension, and one of them could be high aldosterone. So one of the quick ways to assess this is not to order aldosterone, but simply to look at your CMP. If your sodium is elevated with low potassium, that might trigger your suspicion of an aldosterone-secreting tumor, and you need to look at that. So that would be for primary hyperaldosteronism. Secondary, the most common reason is going to be renal artery stenosis, and that's where you get atherosclerosis and narrowing of the renal arteries. Usually just one of them gets narrowed, but it can be both. And there on physical exam, you're going to hear bruits, where you hold the stethoscope, usually over the low back there, or in the abdomen, you're going to hear the sloshing sound of the blood going through the renal arteries. What that's going to do is tell the kidneys to secrete more renin, and that's going to raise aldosterone. Congestive heart failure, liver cirrhosis, or nephrotic syndrome. This all leads to edema with decreased arterial volume. That also causes the kidneys to release more renin. Or you can have an excess of non-aldosterone mineralocorticoids due to taking exogenous mineralocorticoids like fludrocortisone. It's going to be obvious in the patient's history. Having congenital adrenal hyperplasia, remember the most common cause is salt wasting from, with low blood pressure from no aldosterone. But the second most common type of adrenal hyperplasia can cause hypertension and from high aldosterone. So that could be a cause of secondary hyperaldosteronism. And then taking very large amounts of licorice. Remember that licorice prevents the conversion of cortisol into inactive cortisone. And if you take a lot of that, you can get lots of cortisol remaining. The cortisol itself will have a mineralocorticoid effect, and that might mimic hyperaldosteronism. So the assessment for hyperaldosteronism, again, CMP could be very helpful. You might see elevated sodium with hypokalemia and the increased bicarbonate in metabolic alkalosis. And then the kind of definitive test is the ARR. That's the aldosterone and renin ratio test. And so this is a pretty easy test to order. And we're going to actually look at aldosterone and renin levels and look at their ratio. And ARR over 20, some say 30, is pretty much diagnostic of Conn syndrome. If the ARR is less than 30 and the plasma aldosterone is less than 20, and that we can then exclude any sort of aldosterone-producing adenoma. So that's a very helpful test for that. And then there is a sodium suppression test, a more advanced test, where a patient is given a sodium loaded, and then we're going to look for the appropriate suppression of aldosterone. In an aldosterone-secreting tumor, that would not occur. So this is usually done through infusion of saline. Again, this is a more specialized test. You might refer to an endocrinologist. So the treatment, really, this is through level 4 therapies for hyperaldosteronism. We're going to need maybe surgery to try to remove that adrenal adenoma, or medical management through an aldosterone inhibitor, and the main one is spironolactone that can be given to prevent that. And so this would be where we manage that patient's hypertension with spironolactone versus the more typical antihypertensives. And then maybe on top of that, the other types of antihypertensives like ACE inhibitors and ARBs and calcium channel blockers and so forth. So that's a little bit of there. I've had over the years a few patients with presented with fairly high blood pressures, diastolics usually over 95, over 100, or maybe even greater than 100. And we worked them up, and it turns out they did have one. Was very clear. She had an aldosterone secreting tumor, And once that was removed laparoscopically, she had a complete resolution of her elevated blood pressure. All right, so that's just something to consider with secondary hypertension. Finally, I wanted to say a few things about adrenal medulla disorders. So again, we usually think of the adrenal cortex as being the primary source of adrenal pathology, but we can have a disorder of the medulla, and they're going to primarily produce in excess catecholamines. That's going to be the most typical presentation of adrenal medullary disorders. Medullary hyperplasia and underactivity, where we get less secretion, is going to be pretty rare. So typically we don't talk about those clinically, and usually it's going to be the cortical insufficiency that we're going to be more concerned about in the clinic. The primary adrenal medullary disorder to be familiar with are the Pheochromocytomas, and this is a neoplasm of the adrenal medulla. That said, these are very rare, so in my own career over 20 years, I've only seen a couple of these cases. The pheochromocytoma can arise from within the adrenal medulla itself, or from any of the chromaffin tissue, which again, that tissue is catecholamine secreting tissue, which is part of the sympathetic nervous system. So the tumors can also be extra-adrenal. And they can be part of the ganglionic system. So remember the sympathetic chain ganglia on either side of the spinal cord. These are filled with chromaffin cells, and these would be called Perigangliomas if they arise there. Both pheochromocytomas and Perigangliomas, oops, I misspelled that there, Perigangliomas, secrete catecholamines. And the main presentation is going to be severe hypertension. So this is another cause of elevated blood pressure, secondary hypertension. About 1 in 1,000 patients with hypertension actually have these catecholamine secreting tumors, so it's important to keep in your differential. And they can be, many of them in the early stages at least, can be addressed surgically very effectively, and that can eliminate the blood pressure. So generally we see dramatically elevated blood pressure. Systolics can actually go well over 200. Diastolics can go well over 100. So we can go into the hypertensive urgency or emergency situation if we see end organ damage. And we often see flares of blood pressure, and then it goes back to normal. And those flares can be precipitated by exercise, stress, a change in body position. They can relapse and be remitting. Other symptoms might be abdominal and chest pain, palpitations, anxiety, profuse sweating, facial flushing, nausea, vomiting, and so forth. In severe cases, they can induce stroke, heart attack, or other fatal cardiac arrhythmias. There's something called the rule of 10 to help us determine or to kind of get an overview of these tumors. So 10% of them are extra-adrenal, so they're perigangliomas. 10% are bilateral in the adrenals. 10% are actually malignant, not just adenomas. And 10% arise in children. 10% calcify, and 10% occur in conjunction with other endocrine neoplasms, like multiple endocrine neoplasia syndromes. So that's the rule of 10s with pheochromocytomas. The primary assessment is to do 24-hour urine metanephrine and catecholamine testing. So VMA and HMA are the breakdown products of norepinephrine and epinephrine, and dopamine as well. So this is going to be one is to look at 24-hour urine metabolites. The other is going to be to look at plasma-free metanephrine. So both of those would be our diagnostic test. Clonidine suppression test. So clonidine sort of blocks sympathetic outflow, and if these tests are uncertain, then the clonidine can be given. That normally should depress catecholamine outflow, but the catecholamines will remain elevated in the pheochromocytomas. The treatment really can be done medically, and that's first to give alpha blockers. So alpha blockers work on alpha receptors to block the catecholamines there. So phentolamine is a good example. And then you follow with beta blockers. And then alpha blockers should also be given before any surgery, especially surgery to remove the tumors. And always alpha blockers should be given before beta blockers to prevent any hypertensive crisis. The surgery, if it's successful, will be able to remove the actual tumor, and then the problem hopefully is solved. So this again is going to usually go to level 4 therapies here, and definitely if the symptoms are severe enough, this is going to be a referral to endocrinology as well. So that's a pheochromocytoma. Now we see pheochromocytomas primarily in adults, but in children, especially neonates, there are neuroblastomas, and these are malignant tumors of the neurocrest cells that are related to chromaffin cells. These tumors most frequently start in the adrenal glands, but they can also develop in the neck, the chest, the abdomen, and the spine. And it's usually caused by a spontaneous genetic mutation during early development, although they can also be inherited. So there can be a family history of them. And there's something called NMYC mycogene, the N-mycogene, oncogene, which is associated with neuroblastomas. They are the most common cancer in babies, and the third most common cancer in children after leukemia and brain cancer. 90% of cases occur under the age of 5. These are going to be very rare in adults. Usually by the time they're diagnosed, they've already metastasized. And so this accounts for about 15% of all cancer deaths among children from neuroblastomas. The tumors behave in different ways. Some are very aggressive, very malignant. Others are more benign, and some can actually disappear spontaneously. So the typical presentation would be abdominal distension in a neonate, a firm, irregular abdominal mass that can actually cross the midline, versus what's called the Wilms tumor, which is smooth and unilateral. They can have bone pain and also present with what's called opsoclonus myoclonus syndrome, dancing eyes, dancing feet. And this has to do with partly the excess catecholamines that can be secreted here. Hypertension, though, is going to be less common than in a pheochromocytoma. The typical assessment, if you suspect this in a newborn, would be to do an ultrasound, followed by tissue biopsy, and then urine measurement of the dopamine metabolites and then the norepinephrine metabolites. And then it can be staged, low, intermediate, high risk groups based on age, the cancer stage, and the tumor behavior. The high risk stages have very poor survival rates of less than 40% at 5 years. The treatments vary. Sometimes the lower stage tumors can just be observed. You can use surgery to remove, radiation therapy, there's chemotherapy, and now stem cell therapies are being investigated. So that's just to kind of complete our discussion of the adrenal medulla. All right, so that wraps it up for adrenal disorders of the adrenal cortex and the medulla, and also including the functional adrenal disorders.